Doing that, I'll introduce the session and myself as people are gradually coming into the room. So my name is Susan Dent. I'm a medical oncologist at the Duke Cancer Institute in Durham, North Carolina, and I'll be co-chairing this session with Carmen Burgum, who is a radiation oncologist at Washington University. The way this session will work today is we'll have 3 talks, and then we are very fortunate to have 2 individuals who will be sharing their experiences with cardiovascular toxicity. Before we start our session, though, I really do want to thank the organizers of the San Antonio Breast Cancer Symposium for selecting this educational session here today. This is the first time at San Antonio we've had an educational session on cardiovascular toxicity and the impact of our therapies on cardiovascular health, in this case in breast cancer. So with that, welcome to the session, and I think we'll start. I am going to be the first speaker, so Carmen's going to say a few words about me, and then we'll get going.
So thank you all. I also wanted to thank the organizers. And with that, I was going to introduce Dr. Dent, who is a medical oncologist, as she mentioned, and professor of medicine at Duke University. She's the associate director of breast cancer clinical research and the co-director of the cardio-oncology program at Duke Health. And she uses her expertise to promote breast cancer clinical research and provide the best care for cancer patients and foster the cardio-oncology programs.
Thank you. So I have the privilege of being the first speaker in this educational session. And so I thought we would start this educational session and talking a little bit about some of the cancer drugs that we offer our patients with breast cancer. And so what I'm going to talk about, though, is beyond anthracyclines and trastuzumab, cardiotoxicity of some of the newer targeted therapies. The one thing I hear from my colleagues is that we know about anthracyclines, we know about trastuzumab, but it is more than that. So these are my disclosures. So we're going to discuss a little bit today about the cardiovascular toxicity of newer agents in the treatment of patients with breast cancer. And then we're also going to discuss a little bit about comorbidities in our patients, because I think that really does play a significant role in looking at cardiovascular health and how we treat our patients. And then importantly, discuss a multidisciplinary approach to managing cardiovascular toxicities and cardiovascular health in patients with breast cancer. So let's step back a little bit and just look at the issues that women face who are diagnosed with breast cancer. Breast cancer and cardiovascular disease are significant causes of morbidity and mortality in the United States. Cardiovascular disease affects 48 million women approximately, with breast cancer impacting about 3.3 million. So clearly, while breast cancer is an important thing, and that's why we're all here at San Antonio for this meeting, we also have to put it in the context that many of the women that we treat may already have pre-existing cardiovascular disease, or at least be at risk of it. The age-adjusted mortality rates of coronary heart disease and stroke are higher than that of breast cancer. And interestingly, as we see women presenting at an older age with breast cancer, these women, 7 years out from diagnosis, especially postmenopausal women, have a higher mortality risk due to cardiovascular disease than due to breast cancer. So while we are always worried about breast cancer relapse and women dying of breast cancer, they're actually dying of cardiovascular disease in many instances. So when we think about cardiovascular risk in patients with cancer, the first thing that you have to realize is that this is a continuous variable, it's a continuous risk. So when patients come to see us in the clinic and they've been diagnosed, we look at what is their baseline risk. Are they coming to see us with hypertension, diabetes, or other comorbidities? Do they already have pre-existing cardiovascular disease? Have they had another cancer in their childhood, and have they been exposed to cardiovascular agents? And so what is the baseline risk? We then, of course, introduce therapy, and we give them cardiovascular drugs, or actually oncology drugs that may, increase their risk of cardiovascular disease, so that you see perhaps their risk might increase at that time when we're giving them those cancer drugs. And then they move on into the post-treatment phase, where they're at risk of getting older, other conditions, comorbidities, and so on. So there's that variable, that risk of cardiovascular toxicity changes throughout their life, but it's a continuous risk. So we're going to talk a little bit about some of the drugs, specifically cancer drugs, that can lead to cardiovascular toxicity. And the first thing I want to say is that cardiovascular toxicity is not only about anthracyclines. We have learned as medical oncologists and other cancer care providers for years that anthracyclines are toxic to the heart. They can be given in high doses, and they can lead to left ventricular dysfunction and heart failure if they're given in high enough doses. So one thing I will say, that when I was, going through my residency, we always talked about this magical figure of 450 milligrams per meter squared of anthracyclines. We know now that that dose is much lower, and in the more updated guidelines, we say 250 milligram lifetime dose. But some of the cardiologists I talk to say any anthracycline is potentially cardiotoxic. So we always have to be aware of that. So I'm not going to talk about that because we know already a lot about that. We also have learned a lot about trastuzumab. And as we know, trastuzumab, when it was first introduced, it was given in combination with anthracyclines. We learned that was a very bad thing to do. That led to high rates of heart failure. And then we decoupled trastuzumab from anthracyclines, and we saw the risk of heart failure go down. And we've learned how to give that drug. But I would argue it's not just heart failure. And it's not just anthracyclines and trastuzumab. In fact, there are many cancer drugs that we give to our patients now that cause other cardiovascular toxicities beyond heart failure. And those include things such as valvular heart disease, atherosclerosis, myocardial ischemia, pericardial disease, myocarditis, conduction abnormalities, and in some cases, systemic hypertension, pulmonary hypertension, vasospasm. And so it's important when we're thinking about drugs that we're giving our patients, what are the potential cardiovascular toxicities of these agents? So let's step back and look specifically at breast cancer. So this certainly does not represent all of the drugs that we have available to us in the treatment of breast cancer, but just some of them that have associated cardiovascular issues. So as I alluded to, anthracyclines and HER2-targeted agents are associated with heart failure, and we know that. Capecitabine certainly has a risk of coronary vasospasm, and I just saw a patient last week that this happened to, who presented with her after her first cycle of treatment in our emergency department with significant coronary vasospasm. PI3 kinase inhibitors are great, but there is a high risk of hyperglycemia, and this can contribute to metabolic syndrome in this patient population. CDK4/6 inhibitors in combination with an endocrine therapy backbone are the mainstay in first-line setting for a hormone receptor positive disease, but in the case of ribociclib, can cause QTc prolongation. And then we have the HER2-targeted TKIs, HER2 antibody drug conjugates, as we've heard a lot about at this meeting, and checkpoint inhibitors. So I'm just going to talk a little bit about some of the newer drugs. So let's talk about ribociclib. So we know from the MONALEESA studies that there was an increased risk of QTc prolongation. So when you look at the MONALEESA 2, 3, and 7 studies combined, the risk of QTc prolongation was about 7% in patients on ribociclib and endocrine therapy versus 2% in patients on endocrine therapy alone. The good news is that most of those were low grade. There was only a permanent discontinuation rate based on QTc of less than 1%. So they were lower grade, and we learned how to adjust things so that patients could continue. We also learned from MONALEESA 7, so remember that was a study in premenopausal women, that it was not a good idea to give ribociclib with tamoxifen, because tamoxifen in itself places patients at risk of QTc prolongation. And you see to your right that chart showing tamoxifen and ribo are both independent risk factors for QTc prolongation. And so because of this, we know we have to do baseline ECGs and also 2 weeks later, and then on cycle 2, day 1. But what you may not know is that there are some issues with regards to how we measure QTc in oncology. The problem is that there are multiple formula used to measure QTc. The Bassett, the Fredericia, Framingham, and Hodges are some of the more common ones that we use. And the CTCAE does not specify which formula to use while assessing this toxicity. Grade 3 QTc prolongation is a QTc greater than 501 milliseconds, but which formula do you use in the cancer patients to measure this? Many labels and dosing guidelines do not specify which QTc formula to use, and clinicians may not recognize differences in formulas used and the impact in clinical care. So just to show you, this is a slide I borrowed from one of my cardiology colleagues, that these are the 4 most common ways of measuring QTc. What you may not know is that the ECG machines that are in your clinics most commonly use the Bassett formula to measure QTc. Then there's the other 3 formula that I have. So is this the best way to be measuring QTc in our cancer patient population? Well, this study was just published. It was perfect timing for this talk. This was a retrospective analysis of close to 7,000 patients presenting to UNC Cancer Center in North Carolina. They looked at approximately 20,000 EKGs, and they took each EKG and they used 3 of those formulas, so the Framingham, the Friedrich, and the Bassett. And what they found is the Bassett formula, which is the one that's most commonly reported, the one that comes off our ECGs, consistently overestimated the QTc. And the median QTc overestimation was 26 to 28 milliseconds, which means when you're taking that off and you're looking at that, you may be overestimating what truly the QTc is. 81% of grade 3 QTc prolongations by Bassett were actually less than or equal to grade 2 by the other formulas. And so, as highlighted here, this could really be leading to a change in your clinical practice if you're just looking at that formulation. And I want to remind people that when we're thinking about QTc, it's not just the cancer drug. So we know ribociclib is associated with a risk of QTc prolongation, but you have to also remember there are coexisting risk factors such as hypothyroidism, congenital long QT syndrome, myocardial ischemia, and what about concomitant medications such as antidepressants, antiemetics, antibiotics, antipsychotics? And so the drug-drug interaction potentials are large. And there was just a recently very good paper published in Circulation looking at specifically oncology drug-drug interactions that can help guide us looking at that. Of course, you also need a really good pharmacist in your cancer center to help when you're looking at these drug-drug interactions. And then side effects. What if they have nausea or vomiting, electrolyte imbalances, and we know that changes in potassium and magnesium can also impact QTc. So all of these things are important when you're thinking about your patient. It's not just the drug. And so how do we monitor these patients? Fortunately, we have this terrific guideline that was just published by the European Society of Cardiology, a cardio-oncology guideline. And their recommendations specifically for CDK4/6 inhibitors are that we use the Friedreichia formulation for all of our cancer patients. Now, this is too small to read, but you can actually find this online. It's very easy to do. You can just Google it and calculate it yourself. Not surprisingly, they recommended that we do QTc monitoring be done in patients on ribo. We already know that. That's on the product monograph. But they also recommended that even if you're treating patients with abemaciclib or palbociclib, if those patients have other risk factors, you may want to consider watching their QTc, measuring it, and doing ECGs. Now, that was a class 2A, level C recommendation. We don't have a lot of evidence to support that, but it seems reasonable that if patients have other comorbidities and other electrolyte imbalances and so on. And of course, the other recommendation was that you should always be correcting those things, right? So try to avoid drug-drug interactions, try and correct electrolyte imbalances. What about anti-HER2 oral tyrosine kinase inhibitors? We have a number of these available to us in the treatment of breast cancer, including lapatinib, neratinib, tucatinib. And fortunately, most of these have not resulted in a high risk of cardiovascular toxicity. Lapatinib has been associated with increased risk of cardiac adverse events of about 3%, slightly higher when it's combined with trastuzumab and an aromatase inhibitor. Neratinib, an irreversible pan-HER TKI, inhibits HER1, 2, and 4, and we've not seen a lot of excess cardiovascular toxicity. And tucatinib, which we now use in the HER2 CLIMB regimen, also there's been a very little signal for cardiovascular toxicity. So this is actually good news. I don't want to always say it's bad news that these are drugs that we're using in the clinic that have lower risk of cardiovascular toxicity. However, you always have to remember when looking at the data that these trials excluded patients with a cardiac history or reduced LVEF at baseline. Now, this meeting, we've heard a tremendous amount about antibody drug conjugates, and they are changing the landscape in the treatment of HER2-positive advanced cancers and other cancers as well. This is such a rapidly evolving area. This is from ESMO Open, just published, but it keeps changing, and it's hard to keep up with the change in the antibody drug conjugates. The good news is, however, that when we think about these, we don't see high signals for increased risk of cardiovascular toxicity. So a taxane in combination with trastuzumab and pertuzumab remains the standard first-line therapy. We've heard at this meeting and reassurance that trastuzumab and deruxtecan has now clearly established its role as a preferred second-line therapy. And then we have TDM1 and other targeted agents further down the line that patients have access to. But what is the risk, and what have we seen in terms of reported cardiovascular toxicity? So we actually just published this in JACC Cardio-Oncology earlier this year, looking specifically at this question. And what is interesting is that if you look at the original dual targeted therapies and then Cleopatra and compare that to Destiny 03, we've not seen a great deal of increase in reported LV dysfunction. Now, there was a little bit more in the trastuzumab deruxtecan arm in Destiny 3 compared to TDM1, but not by a large amount and not more than that we've seen in other HER2-targeted agents. So that's reassuring that that's happening. And even as you go further down the line in terms of treatment choices for patients, such as the SOPHIA trial with margetuximab, we've not seen a lot of extra LV dysfunction. The issue is there's been limited experience in real-world settings with some of these drugs. We clearly need longer follow-up. And then the question becomes, okay, so we're not seeing larger amounts of cardiovascular toxicity, but how do we monitor these women? Well, how should we monitor them in terms of their cardiovascular issues? And so if you look at how the studies were done, of course, there was very close cardiovascular monitoring while they're on study. But in the real world, when these women are in our practice, some of us do none. So what is the answer? Do we do some? Do we do none? What we do know is that if women are going to run into trouble, they tend to do it early. They tend to do it within that first year. So on the bottom of this diagram, this illustration, we propose that it might not be unreasonable to do some cardiovascular monitoring, echoes, and look at LV function and LVEF early on in the course of treatment with these agents. And then if patients are stable and they're doing well, then you can do it as clinically indicated. And one would say, well, why would I do that? These are patients with advanced breast cancer. Why does it matter? I think as we keep pushing the envelope and we see women now surviving 60 months and more, this is really becoming a chronic disease for women. And so what we want to make sure is that they are able to continue to tolerate these therapies moving forward. And so this is they're not evidence-based, but this is sort of a consensus from amongst a number of us that maybe we should do a little bit of monitoring early on. If they're fine, then just follow them clinically. And of course, immune checkpoint inhibitors has really transformed how we treat cancer globally across all the solid tumor sites. We now have access to PD-1, PD-L1, LAG-3, CTLA-4, inhibitors. And when we look at the FDA-approved immune checkpoint inhibitor list, you can clearly see here all of the different types of cancer that now have drug approvals. And of course, breast cancer is there, and pembrolizumab, we know now, is approved in the advanced setting and also a neoadjuvant adjuvant setting as well. But what is the cardiovascular toxicity associated with immune checkpoint inhibitors? Well, you see here, the one that actually has gained the most attention and most concern is myocarditis. Myocarditis is not that common. It occurs in about 1 to 2.5% at tops patients treated with immune checkpoint inhibitors. It tends to occur relatively early with a median onset of about 30 days, and it tends to occur within the first few cycles of patients receiving that. But if patients do get that, the issue is it's very high rate of fatality, so about 50% of these people will die from myocarditis. So it's not something that you want to miss. And I just want to tell you, about 2 hours ago, I got a call from the CCU at Duke University about one of my patients on pembrolizumab, who's now admitted with possibly myocarditis. So it's rare, but I'm just saying it can happen. Of course, it's not just about myocarditis. You can also have pericarditis, pericardial effusions, cardiac arrhythmias, myocardial infarction. They're really rare. But this is just for you to realize that these drugs, we know they cause a lot of itises, including itis to the heart. In terms of who's at risk, the risk factors, the higher risk factors are patients who are on combination immune checkpoint inhibitors. So if you're on 2 of them versus 1, combination of cardiotoxic therapies with immune checkpoint inhibitors, or if they've had prior myocardial injury. But also you have to think about, do they have pre-existing autoimmune disease? So many of our patients do have things like rheumatoid arthritis, lupus, sarcoidosis. All of these things will place patients at higher risk. And when you look at symptoms, this is where it can get a bit tricky because the symptoms can be very vague. So fatigue, muscle pain, fever, chest pain, shortness of breath, palpitations, all the things that we can see with our patients, and that may occur for other reasons. So in the real world setting, what are we seeing? This is just published a few months ago, this retrospective study of close to 2,500 patients with cancer treated with ICI therapy over a 6-year period at the Royal Marsden in the UK. And 110 patients, so still a small number, were referred to the cardio-oncology service. 89 patients experienced an adverse cardiovascular event, with myocarditis being the most common diagnosis, followed by tachyarrhythmias, left ventricular dysfunction, and pericarditis. And I just want to show you, even though the numbers are very small, that in green, the arrow is pointing to in green, so those are patients with breast cancer. So it is starting to show up in breast cancer. Remember, we have not used immune checkpoint inhibitors for that long in breast cancer itself. And so how do we assess these patients and monitor them? Again, I point to the European Society of Cardiology guidelines that suggest that it's very important when you're starting patients on these therapies to do a cardiovascular risk assessment, an ECG, if they're at high risk, perhaps an echocardiogram, and you can see those written recommendations there and the levels of evidence. And it's all really about trying to prevent this type of toxicity from happening. So I've talked a lot about, those are some examples of the cancer drugs that we use and the potential cardiovascular toxicity. But what about the actual person themselves? I think we focus so much on the cancer drugs, what they'll do in terms of, response rates and overall survival. And I've just told you that some of these drugs can cause cardiovascular toxicity. But we have to really think about the individual person. And so I advocate in this article published recently, moving away from that disease-centric approach to a person-centric model. And what that really speaks to is the fact that you have to look at what you're giving that individual in the context of their genetics, their lifestyle behaviors, environment, social determinants of health. And where are they in their life in terms of cardiovascular risk and disease? Do they have diabetes? If so, is it controlled? Do they have hypertension? Is it controlled? What about dyslipidemia? Because all of these factors are going to impact your ability to deliver that cancer care, and more importantly, it's going to impact their overall mortality and morbidity. And in fact, when you look at breast cancer patients, most of them come to us with at least one comorbidity. And if we don't treat those appropriately and manage those, then we're placing those individuals at higher risk of perhaps a preventable cardiac death. And that's clearly not what we want to do when we're treating these patients. So management of cardiometabolic comorbidities is really, I think, essential when we're treating our patients. The problem is who does that? I recognize as, oncologists and other cancer providers, we don't have the time to manage hypertension. We don't have the time to check their lipids always. And so this is where I think a team-based approach is so important. A team-based approach, by that I mean their primary care provider. Maybe it's a cardiologist, maybe it's an exercise physiologist, maybe it's an APP, nurse practitioner. But really what we want to do is optimize the cancer and the non-cancer therapy using this team-based approach. Most cardiovascular disease risk arises from inattention to the management of these risk factors. And there's recognizing that, that's important. The other thing I want to highlight is there's really a paucity of evidence-based guidelines among cancer survivors. And we have these cancer survivorship plans that many of us cringed at the thought of doing, and it really focuses on looking at risk of cancer recurrence, but it doesn't really speak to management of cardiovascular risks and other risk factors. And so, as an oncologist treating breast cancer, my objective is to give the best possible cancer care to our patients. At the same time, it really is, I think, essential that we try and optimize cardiovascular health. And so cardio-oncology is really a clinically based discipline that has emerged over the last 10 to 15 years, focused on the cardiovascular health of cancer patients and cancer survivors. This field has really grown in the last several years, and now there are a number of cardio-oncology partnerships and endorsements from organizations such as ASCO, such as ESMO, the Cardiology Association, such as the European Society of Cardiology I mentioned, the AHA, American Heart Association, the American College of Cardiology, the Canadian Cardiovascular Society. All of these entities and bodies are endorsing this partnership. And we, I should say, a group of us have come together and formed the International Cardio-Oncology Society, which now has 800 members from over 23 countries, with our mission and our goal of delivering the best cancer care that we can to our patients while optimizing their cardiovascular health. And so I'll leave you with this guideline that I alluded to earlier, but this guideline, which is 133 pages long, so you have to take it in parts, was produced during COVID, and we produced this guideline with not one single in-person meeting. This was all done on Zoom calls, by the way, across the ocean. It really speaks to looking at ways we can try and help our patients, not only give them the best cancer care, but make sure we're doing no harm to their health. It's available also online right now. They're publishing an ESC pocket guideline, so you can carry this around on your phone. So in conclusion, I just really want to say many cancer drugs are associated with an increased risk of cardiovascular toxicity. And that risk in patients, particularly any patient, but breast cancer patients, is dependent on both the individual risk factors, such as comorbidities, as well as treatment-related factors. And so I think we have to move away from the siloed approach of looking just at what we do with the cancer drugs to a more team-based approach. I'll call that our cardio-oncology approach to optimize cancer therapy and cardiovascular health. So with that, I'll end my talk, and thank you.